Welcome to Module 5, Topic 5.5, Research Methodology in Nutrition Research. In the last module, 5.4, we learned to identify gaps in research, determine a research question to address these gaps and a problem that needs to be solved, develop general and specific aims along with hypotheses for each, and to determine the significance and innovation of a study. In this module, we will overview the different methodologic components that we need to consider while developing our study. First, we have to define the study population and the sample. The study population is the entire group of interest determined by our research question. And these should be defined by geographic location, age, sex or gender, and any other additional attribute that's relevant for the research question. That's the key piece, is that it needs to be relevant for the research question. You may be interested in how a particular exposure to pesticides affects men and women who work in wheat fields. Therefore, you'll want to know their occupation, that they work in a wheat field. An example here is, what is the effect of breastfeeding on infant development in the Salavan province? The study population would be all infants, defined as 0 to 1 years old, from the Salavan province at a given time point. The study sample is a part of the fully defined study population. When we can't measure the entire population, which is very rare that we can, we take a sample. We want a representative sample because that is best for accurate study results and more rigorous research. And probability sampling gives us the best chance of having a representative sample. And in probability sampling, the chance of selecting each member of the population is known. For an example, the study population of infants from the Salavan province, our sample may be 10% of infants 0 to 1 years from Salavan province at a given time point. And this is, of course, provided that the sample was properly conducted and the exclusion and inclusion criteria for the study were well defined. Some sampling methods, and we will talk a little more about this in Module 6 as well, are probability samples or non-probability samples. Non-probability samples include convenience samples and snowball samples, although sometimes snowball samples they can be more rigorous than a convenience sample, particularly when paired with certain analytic techniques. But in non-probability samples, participants agree to be included in the study voluntarily, and it's usually a convenient method for captive populations or people that are easy to reach. It also allows for recommendation of new cases from enrolled cases. So you can have participants recommend others that they know into the study. However, it's not very generalizable. You can't take a non-probability sample and say the results from this study we believe apply to every kind of person in this group. In simple random sampling, every member of a population has an equal chance of being selected. But this is better to use when your whole population is available. In systematic sampling, you have a list of everyone in the population, and you select the participants by a systematic method in which every nth or kth person, some number person is selected from the list. And you choose the first person through a random process. You can use this when part of a representative people are available. Stratified random sampling is usually used when we want to study specific subgroups of the population. For example, men and women, or people who were born male and people who were born female. When there's an uneven distribution of the population, we can also do this for age, socioeconomic condition. We can stratify the sample according to that factor. So we separate men and women, put them each into a stratum, and then within each stratum, we take a random sample of participants. We randomly select participants. In cluster sampling, participants are recruited in clusters or naturally occurring groups, and those groups are randomly selected. For example, households or schools. We can use this often when the population groups are separate and accessing all of them is difficult. So good examples of this are schools, neighborhoods, households. There are many study designs that can be used in nutrition research and all research, and we are going to talk more about these in Module 6. Every design has strengths and limitations, but it's very important to just acknowledge the strengths and the limitations of a study design when you're conducting a study and when you are communicating about that study. People are researchers and are well aware of the strengths and limitations of study designs, and they will want to make sure that you are recognizing those and including those limitations in your description of your results. Study design will depend on the level of the data. Are we collecting new data? Do we have secondary data? Was it collected on a population level or from individuals? The time frame of the study and data collection, the research question, the costs and resources. We would all love to do randomized controlled trials, but they're often cost and resource prohibitive. And it'll also depend on the latency and the frequency of the outcome. So you'll find that we may choose studies differently for diseases with rare diseases versus rare exposures. This is a representation of types of study designs. We have descriptive and analytical study designs. We will go into more detail about this in Module 6. As an overview, descriptive studies usually describe the distribution of one or more variables without an a priori hypothesis. I would like to think of those as the who, what, where, and when studies. One type of study design is a case report or a case series. Case reports describe an individual case with an unusual condition. We typically see a case report when a disease is rare or when we are first seeing a disease. So you can look in the publications for the description of the first Zika virus case or the first case of pneumocystis carinii pneumonia in a person with HIV in the United States. In a case series, this will describe several consecutive cases with an unusual condition. So once they described 6 or so men in the United States with pneumocystis carinii pneumonia and who were immunocompromised, they were able to put together a case series of the first individuals with AIDS in the United States. The pros of these are they are used to identify or describe unrecognizable diseases or conditions and can recognize emerging diseases or new gaps. The cons are they're anecdotal, they're descriptive, they're usually of one person, one patient, or one disease with a couple of patients in the case series. So they have limited value, but they are good for historical reasons as well as recognizing the emergence of a new health problem. Cross-sectional studies describe the distribution of one or multiple factors. We can also call them prevalence studies, are a type of cross-sectional study. They're usually a snapshot of the frequency of a risk factor and an outcome, but the measurement of an exposure and outcome are taken at the same time. They're a little easier to conduct. They may be more simple or inexpensive. This is an example of survey research. But there is no information that you have on causality in a cross-sectional study. You can only say that an exposure and outcome were both occurring at the same time, and you can look at the relationship between the prevalence of a risk factor or exposure and the prevalence of an outcome in a population. Analytic studies examine associations by measuring the relationship between risk factors on specific outcomes, and you typically have a hypothesized causal effect or a hypothesized direction. In observational studies, the investigator observes the individual without actually intervening on them or with them. Cross-sectional, again, can be an example of this type of design. This describes the relationship of the exposure and outcome measured at one time point. They can be done, you can measure multiple exposures and outcomes in a cross-sectional study, and they often provide a foundation for other studies. However, again, you don't have any information on on the direction of causality. You cannot tell if it's more difficult to establish if the exposure preceded the disease. In case control studies, we identify individuals with a particular outcome or disease who are the cases. We match them with controls who do not have the disease, and then we retrospectively go back and look at differences in the exposure or exposures in the cases and controls. This is a less expensive and time-consuming study design than cohorts or randomized trials. And it's often used for rare diseases and diseases with long incubation periods. It's not good for rare exposures, and it can be prone to bias. In a cohort study, you follow individuals and compare those who are exposed and those who are unexposed to a particular risk factor to see who develops the outcome. This is a way of measuring disease incidence. We know the exposure is measured before the outcome, and it's much better for rare exposures, while the case control study is good for rare outcomes or diseases. Cons to cohort studies or problems with cohort studies is that there's a greater loss during follow-up or attrition. They're more expensive and time-consuming, and they are often better and more rigorous when they have larger samples. It can be difficult to find funding for a cohort study. And finally, we have experimental or interventional trials in which investigators administer the intervention. This includes randomized controlled trials, non-randomized controlled trials, cluster randomized trials. And in these, you're able to look at the distribution of potential confounders because you are randomizing individuals into a exposure or control group. It does give us the highest level of evidence. It's the gold standard, but you cannot randomize for every type of relationship. You cannot randomize people to be smokers or non-smokers and see who develops lung cancer. You cannot randomize people to have malnutrition and not have malnutrition. So it can, there are a lot of ethical considerations that go into randomized control trials. They're also very expensive, and they just don't work for all situations. The correct design for a study will be related to the type of data that's available or that we are planning to collect. We think of primary data as data that you have collected yourself as the researcher. So you may use primary data for a case series, cross-sectional studies, case control studies, cohort, experimental, and qualitative studies. Secondary data, studies using secondary data are common, and these you'll often see national survey data that other people then use in their own studies. That's an example of using secondary data. And then tertiary data we can use to describe studies that are reviews or meta-analyses. Primary data are collected and analyzed to answer specific questions. We start from zero, we do not have data, and then we collect the data and analyze it. The pros are that this is original data that's specific, that we need for our research question. We get to ask what questions that we want to ask or collect all of the data that we would like to collect that's feasible. The data are more current. It helps you to avoid bias, and you can be more flexible in what you can or can't collect if you are the individual or the team that is collecting the data. But again, it can be very time-consuming and costly. And secondary data uses existing data sets and variables that were collected for a specific purpose, but the data can be used to answer other research questions. This is much less expensive, although you do often have to pay for secondary data sets for secondary data analysis. Some have very large sample sizes that may require sophisticated statistical analysis skills to analyze. It's usually data from the past, and you have to take that into consideration when you may need current, up-to-date data. Bias can't be ruled out if we don't have all the covariates of interest, and it's less flexible. You can't add any variables to a secondary data set unless you're able to connect those specific individuals to primary data that you've collected. An example of secondary data is census data. In tertiary data, this is results published in previous literature that you can aggregate for reviews and meta-analyses. This is beneficial for when you want to look at inconsistencies of results across studies or get a very thorough in-depth review of the type of studies that have been conducted in an area and the nuances of effect size that perhaps have been found for a particular relationship. However, you need enough studies and adequate sample sizes within those studies to draw conclusions when you're doing a meta-analysis. The original studies can introduce bias that will then bias your tertiary data study. Once we determine the data type for our study, we have to consider the sources or instruments that we need to collect the information. This depends on the research question, the study population, the available budget and resources in our timeline. They can be qualitative, quantitative. This all really depends on the research question. Data collection methods, which we will talk about more in Module 6, can include surveys, interviews, focus groups, biomedical, biochemical, clinical examinations, medical records, other types of records data. There are specific tools and techniques that we can use to collect dietary and nutritional information and data. They all have their own strengths and limitations, and use will, of course, always depend on the research question. Some of these tools include dietary assessment, like 24-hour recall of food frequency questionnaires, anthropometric and body composition tools, classic measures such as weight and height and abdominal circumference, up through newer, more expensive measures like X-ray, body density. Physical activity can be measured with accelerometers, pedometers, questionnaires, or calorimetry. How do we define variables in nutrition research? Which variables you use will depend on the study design, research question, and level of analysis. In general, nutrition variables range from the smallest nutrient level measured using biomarkers to more general dietary patterns, such as in an individual or even on a community or geographic level. When choosing nutrition variables, we also need to consider the level of organization of the exposure variable, which assessment to use if you have repeat measurements of diet, potential interactions or joint association of nutrients, interpretation of your results, and other variables that will be a part of your study. So let's talk about some of these different levels of measurement. Dietary biomarkers are biochemical indicators of nutrient intake that can be either recent or long-term, and or markers of the metabolic consequences of dietary intake. These are objective measurements, and they're considered the gold standard in measuring nutrient intake, reducing bias and misclassification errors that are common in dietary assessments. Types of biomarkers include recovery. This estimates the absolute intake levels in a certain period of time, for example, urine nitrogen as a measure for protein intake. Concentration measures the concentration of specific nutrients in the body, so the amount of folic acid in your plasma. And adherent, so monitoring specific dietary regimens. There's omega-3 fatty acids for fish oil supplementation. And here some considerations are taking into account the measurement time. Are you going to be able to measure what someone consumed recently or over a long term, and which is most appropriate for your research question? Human error that can occur. They can be affected by non-dietary determinants like smoking or genetics. Ethical issues in being able to collect and keep this type of biomedical data. And it's not suitable for all nutrients, for example, fiber. On a nutrient level, there are several health outcomes that are ultimately related to specific nutrients. So this measurement level can be very desirable in nutritional epidemiology. However, we do have to consider that nutrients are often intercorrelated. So any nutrient association with disease may be confounded by other nutrients present in the food items. And also that the intake of one nutrient can be modified by or modify other nutrients, its absorption, metabolism, and the requirement of that nutrient. We have to make sure we identify supplementation. When we study nutrients, are people taking supplements? And also total nutrient intake accounts for a more powerful test compared to just the nutrients in one food item, as nutrients are distributed over many food items. Measuring food items in groups. The type and amount of food eaten are non-dietary determinants for the risk of disease. We eat food, not nutrients, so measuring food items in groups does provide an advantage for looking at associations between food groups and diseases. Food items and groups are realistically closer to dietary recommendations and are a bit easier to understand for most individuals. But food structure is complex, and there may be a lot of interaction between nutrients and substances that could potentially affect bioavailability and absorption of different nutrients. So ideally, we need to analyze both nutrients and food items to account for potential underlying mechanisms. And finally, when we're thinking of dietary patterns, these really account for many of the limitations in traditional analysis, multicollinearity, confounding, and some diluted effects. They're ideal to test the effect of macronutrients in food consumption, as well as overall energy intake, and particularly relevant for outcomes that are related to multiple dietary components. And results are more generalizable, but only when the patterns are repeated in other populations. Anthropometric measures are the most used measures to assess nutritional status. So the classic measurements, weight, height, BMI, are more simple to collect than other variables. And more complex measurements may require training or a trained professional. But in research studies, we need to make sure that there's an optimal precision and accuracy on the collection of these measurements. And in that case, that's where training personnel of research studies is very important. But the resources that you have in your study, equipment, personnel, time, and budget, might affect the accuracy of measurements or require more of a reliance on self-reported measures if you're unable to provide the resources for different types of measurement tools. Physical activity is fundamental in determining how energy expenditure varies between people. You have to consider the type, duration, frequency, and the intensity of exercise. And the measurement of this relies on resources available for the study. The more precise and detailed information, as well as long-term physical activity patterns, are critical to account for the effect of physical activity as a measurement of energy expenditure, as a risk factor for diseases, and in confounding other associations that you may be trying to measure. There are multiple ways to analyze nutrition variables and also to manage and transform data that you're using in your analysis. And your choice of method will depend on the research question and on the type of data that you have available. Ideally, the analytic technique must be determined during study planning and not after collecting the data to avoid what we call fishing for correlations. So you should have an a priori hypothesis and analytic plan to test that hypothesis. One common data management and analytic technique that you're going to use in nutrition research is categorization. And this is really helpful with in particular food items or groups. So for example, you can have fish consumption be measured as less than once a month, 1 to 3 times a week, 1 time a week, etc., rather than perhaps the amount of fish on every day. And this, of course, will vary with your tool, but categorization does help make data visualization easier, and it may be easier to show the intake with dietary recommendations. It also reduces the effect of outliers. If you have very few people who eat fish, say less than once a month, or very few more than 5 times a week, categorization kind of reduces that issue. Similarly, you may categorize your nutrient data into quantiles or quantile distribution, which can also help reduce the effect of outliers. And one example of this is in omega-3 fatty acids, which are often measured in quartile intake. A continuous distribution. This is useful in nutrient and biomarker data. It increases the power of the analysis. You can look at confounders. This may be an example of measuring the milligram intake of these particular acids. As I mentioned before, you do have to take into consideration in your analysis repeated measurements. We have multiple measurements over time. You may be selecting one time point for the analysis based on your research question, or you may be looking at the changes over time. But we can use the most recent measurement, we can use baseline data, we can use cumulative averages. It depends on what your research question is, but make sure that you are considering a time point when you have repeated measurements. Similarly, make sure, again, that we're considering the interactions and associations between food item group and dietary patterns data. So when you're measuring kind of the same thing on multiple levels, and also synergistic or antagonistic effect of particular nutrients that will interact with one another. An example is omega-3 fatty acids and the mercury in fish. There are many other analytical issues that you have to consider in nutrition research, and these we will also discuss in Module 7. Missing data should be explored to understand patterns of missingness. You can use imputation rather than deleting them from the data set. Subgroup analysis is important and should be considered when there's clinical or biological reasons that could affect the estimates. Folic acid requirement between men and women. And typically, in most research, there are differences between men and women, and looking at those gender differences can be very important and is often neglected. Measurement error. There's often measurement error in nutrition research, and it results in biased estimates of an association, but that the severity and the nature of that bias depends on the type of error, and in some cases it can be corrected. Mediation effects. So sometimes we see that an exposure outcome relationship can be mediated by a third variable, and that should be explored in longitudinal data, particularly when we're suggesting causality. And null associations can be an effect of the random variation in the data, while systematic variation can bias the association in either direction. So key messages from this section are study populations we need to define by geographic location, age, sex, and other relevant attributes. Samples are best when they are representative and lead to more accurate and rigorous findings. Sampling method will vary depending on the research question and your study limitations. The study design will depend on research question, study limitations, and available data and resources. Once we determine the data type, we have to consider the sources or instruments needed to collect the information if we are collecting primary data. Nutritional data can be collected by different tools, including 24-hour recall, other questionnaires, biomarkers, anthropometric measurements, and physical activity. But selection of this tool depends on your research question and your variables of interest. The data analysis technique will also depend on the available data and research question, but always consider limitations and strengths of each technique. Data exploration before analysis is important to make sure that you are preventing or correcting any analytical issue that could affect the results. So, an exercise based on the research aim and hypothesis, again, that you developed in Module 5.4, considering the structure of your data. What type of data are we using? Is it primary, secondary, tertiary? What are the potential study designs that you could propose for your study? What analytic techniques could potentially be used in the study? And are there any considerations that must be taken into account for your study, particularly regarding measurement or study population? Thank you so much, and let us know if you have any questions.